I'm Dr. Nasmani, and this video session is the second part of the small for gestational age infant. So we are resuming from the part 1 on the etiology of IUGR. There are three factors which I already told you: maternal, placental or fetal factors. 1/3 of IUGR are due to genetic causes, 2/3 are related to the intrauterine environment. No underlying etiology can be identified in at least 40% of SGA infants. Severe maternal starvation during pregnancy, maternal hypoxia, then hematologic and immunologic disorders that cause thrombosis of the intervillous space and decrease uteroplacental perfusion, maternal medical disorders like nephropathy, collagen vascular disease, and obstetric complications like preeclampsia associated vasculopathy, virus and parasite like rubella, plasma, toxoplasma, cytomegalovirus, varicella, malaria, which can access the fetus transplacentally or across the intact fetal membrane. Maternal substance abuse, including cigarette smoking, alcohol, and illicit drug use. Toxic exposure, including various drugs like warfarin, anticonvulsant, anti-neoplastic drugs, and folic acid antagonist. High altitude. And then demographic variables, including race, pregnancy at the extremes of reproductive life, maternal age at first birth, and then early parity or grand multiparity, and previous delivery of SGA newborn. These are the maternal factors which cause SGA. Now look at the placental factors and neonatal factors. Placental factors are any mismatch between fetal nutritional or respiratory demands and placental supply can result in impaired fetal growth. IUGR results from an accumulation of placental injuries such as abnormal uteroplacental vasculature, chronic inflammatory lesion, abruptio placenta, thrombophilia related uteroplacental pathology, and gross placental structural abnormalities such as single umbilical artery, filamentous umbilical cord insertion, and placental hemangioma. Neonatal factors: karyotypic abnormalities such as trisomy, autosomal deletion, ring chromosome, uniparental disomy, confined placental mosaicism. Presence of a chromosomal abnormality often result in the appearance of IUGR early in pregnancy, most likely of symmetric type. Genetic syndromes like Bloom syndrome, dwarfism, Russell-Silver syndrome, and major congenital anomaly in one study. Reviewing data from National Birth Defect Prevention Study, infants with congenital heart disease, in particular conotruncal and septal defect, were twice as likely to be SGA compared to those without a birth defect. That is 15% versus 7.5%. Multiple gestation is related to fetal growth abnormality in that relationship to the number of fetus present. That's understandable. Now in this picture on the clinical features, I am showing you two photographs. The infant on the left side of shows the infant has the typical shrunken or wizened appearance of an SGA infant. The infant on the right side has the characteristic appearance of SGA infant. Note the loose peeling skin, decreased subcutaneous tissue and muscle mass, and meconium staining. The SGA infant appear thin with loose peeling skin and decreased skeletal muscle mass and subcutaneous fat tissue. The face has a typical shrunken or wizened appearance, and the umbilical cord often is thin. Meconium staining may be present in newborn. With asymmetric IUGR, the head appears relatively large compared to the size of the trunk and extremities, and it should not be mistaken for hydrocephalus. The gestational age assessment. Physical criteria used to assess gestational age are altered in SGA infants. For example, decreased vernix production associated with the reduction in either estriol synthesis or skin perfusion leads to increased exposure of the skin to amniotic fluid. Neurologic assessment is reliable in SGA infants with a normal nervous system only. Now we shall look into the complications of SGA. Deprivation of oxygen and nutrients is one big problem. Difficult cardiopulmonary transition with the perinatal asphyxia, meconium aspiration, or persistent pulmonary hypertension is the first problem usually we come across. If the baby is SGA plus premature infant, that is infant with IUGR who are delivered before term, may also have other complications of prematurity. Greater rate of neonatal death, necrotizing enterocolitis, respiratory distress syndrome are high. Administration of prenatal glucocorticoid reduces the risk of RDS, severe intraventricular hemorrhage, and death in SGA infants plus prematurity is seen. Now, regarding thermoregulation, there is impaired thermoregulation because of increased heat loss and reduced heat production, reduced subcutaneous fat, depletion of catecholamines which are needed for thermogenesis by brown fat by intrauterine stress, and reduced availability of nutrient substrates. Hypoglycemia. Risk of hypoglycemia correlates with the severity of growth restriction. Low intrauterine insulin concentration result in decreased glycogen synthesis and reduced glycogen store. Then polycythemia and hyperviscosity. There is a risk of polycythemia in SGA babies, and this increases with the severity of growth restriction. Then impaired immune function. Cellular immunity is impaired in IUGR infants in the newborn period and during childhood. T and B peripheral lymphocytes are decreased at birth, which is shown by various studies. Perinatal mortality. Increased perinatal mortality is seen in SGA compared to AGA infants. Congenital malformation, perinatal asphyxia, transitional cardiorespiratory disorders contribute to the high mortality rate. So what are the important things which you have to keep in mind during management? One is problems can be anticipated because mother will be reporting to you early in pregnancy itself, which help us to diagnose by USG and other features. Delivery of the affected infant should be planned in a center where you can take care of such babies, attended by qualified pediatricians and pediatric nurseries. Etiology of IUGR should be investigated before and after delivery. Then after delivery, attend to the congenital malformations, chromosomal abnormality and congenital infection. Radiant warmer should be available for the thermoregulation. Proper resuscitation and presence of a neonatologist before at the time of delivery, so that before delivery itself you should be well informed. Sufficient time for him to come and be there in the cesarean room or the labor room. Clearing the area of meconium is very important at the time of delivery before the first cry. Then meconium aspiration pneumonia, myocardial dysfunction, persistent pulmonary hypertension should be managed in the NICU. Enteral feeding and intravenous nutrition should be provided during the stay in the NICU. Then once you admit in the NICU, monitor for hypoglycemia, that is low plasma glucose less than 40 should not be there, so it is your duty to keep the feeding good. Then hypocalcemia is another problem which can occur. What are the important outcomes of SGA babies? Regarding physical growth during the first 6 to 12 months after birth may be accelerated, and many of the babies have catch-up growth. Then regarding neurodevelopmental outcome, increased the risk for neurodevelopmental abnormalities and decreased cognitive performance has been reported in many studies. So such babies should be under proper periodic review, and vision, hearing and motor and other milestones should be recorded periodically, and its importance should be told to the mother. Then relationship to adult disorders is one hypothesis, that is increased the risk for ischemic heart disease, that is fetal origin of adult disease theory, or what is called a Barker hypothesis. They say that in SGA babies the adult diseases occur much earlier. Fetal undernutrition results in changes in vascular development that predisposes to adult disease such as hypertension, stroke, diabetes and hypercholesterolemia. That is called a Barker hypothesis. So hope that you have followed the session very well, and please contact me in the email address given. Please visit the channel or the site www.youtube.com/ACEPGMed. If you got Facebook account, please make friends with facebook.com/ACEPGMed. After inviting as friend, please click like. Thank you.